I think I was supposed to declare my interest. I'm actually in the young elder group, so I do have a stake in this conversation. Okay, so I'm the clinical lead for care at the end of life, which is part of the statewide strategy, and I'll talk about that in a second. There we go. So the Queensland statewide strategy is something that's been developed over the past few years. It came out of Parliamentary Committee report in 2012, and Queensland Health, Queensland Clinical Senate and Health Consumers Queensland developed the strategy. It's an apolitical process. Both sides of the spectrum, ends of the spectrum embraced it. When they changed government, there was no hiccups as it was handed over, and we have really good executive buy-in across Queensland Health. It really has the long-term goal of cultural change, and it's not just Queensland Health, because our patients don't just live in Queensland Health. They live in residential aged care facilities, primary care, private hospitals, and across the community generally. So it's a whole of Queensland exercise. And the aim is really to improve the ways that we deal with death, both as patients and as clinicians. And I think it's fair to say that what we're finding is that in many ways the community is actually ahead of us in its acceptance of the normality of death. There are four main streams. I'm just giving you the background to what my job is really, first of all, is to improve death awareness and to encourage open discussion and advanced care planning in the community generally, to identify patients for whom advanced care planning and the goals of care should be considered early on in their lives and their illnesses, improve skills of all clinicians in communication about death and dying and the provision of care at the end of life, and finally to make sure that appropriate palliative care is available across the state. So that's the summary of what the project's about. Now in 2008 I saw this article in the Internal Medicine Journal, which is the journal of the College of Physicians, of which my specialty is a part. And the geriatric syndromes are predictors of adverse outcomes in hospitalisation. I was really surprised to see that death in hospital or during 3 months post-discharge was deemed to be an adverse outcome for a geriatric population over the age of 75. So I wrote a letter, and I'll describe that later on or at the end. It seemed to me that death can be a normal outcome for someone over the age of 75, so I didn't think that was a fair thing to do. So I thought it was worth just providing a bit of context for thinking about death and dying. So this was my great-grandfather, who was born in 1850. And at the time he was born, these are the life tables, the Kaplan-Meier curves for the population of England, and also for the people who live in the Kalahari Desert. Anyone see The Gods Must Be Crazy with the Coke bottle thing? That's them. So you can see that in England and hunter-gatherers, there wasn't really much different in their population curves. And the interesting thing is that the mortality in childhood before the age of 10 was about 30 or 40%. But if you reach the age of 10, you had a 50% chance of reaching about 60 or 65. And a few people lingered on to reach 100. And that's really interesting because everyone says, oh yeah, everyone was dead by the age of 40, but that wasn't the case at all. In fact, if you look at the life tables of other animals like penguins, they have a very similar life curve, although the maximum life expectancy is shorter. So they're very high mortality in childhood as a penguin, but if you survive the first couple of years, you actually have a pretty good chance of reaching 15 or 20 or maybe even 25 or 30 years old. So this is the way we've evolved over a long period of time. Now this is the picture of the wedding of my grandparents, who were both born in, my paternal grandparents, who were both born in 1896. My grandfather was born in Australia, that's the yellow line, and the purple line is the UK, or England. And in Australia, which had the best quality of life in the world at that time, life expectancy was improving more significantly. That was really about, I guess, what we would call public health measures: good food, better housing, better environment generally. And England was lagging behind at that time. So when I was born in 1949, hence my categorisation as a young elderly person, my grandfather was actually a neurosurgeon, as fate would have it. When I was born, life expectancy was very different. By then, fewer than 5% of people in Australia died before the age of 10. But you can also see, as in the previous graph, that mortality in all these lines converges at about the age of 100. So what we've done is shifted the curve up and decreased childhood mortality. So when my grandson was born 3 years ago, you can see that in Australia, fewer than 1% of people die before the age of 20, except for the Aboriginal population, which is just below 1%. And fewer than 10% die before the age of 65. But between the age of 65 and 100, the other 90% die basically, except for a few people linger on over 100. So for another perspective, for 10 to 20,000 generations, or that's 200 to 400,000 years since we emerged from the scrum of our genus, the median human life expectancy was about 40 years, and 30 or 40% of people died in childhood. And just over 6 or 7 generations, my family, I've met my great-grandfather, not the one who was born in 1850, but the other one. Over 6 or 7 generations, the life expectancy has doubled to about 80, and now 90% of deaths occur in people over the age of 65. But the treatment paradigm that got us to this point doesn't work for the elderly, because our success has come from preventing diseases and treating diseases, not from treating old age. And there was a recently publication in Nature which found that the life expectancy, or the age at death of the oldest person in the world who's died over the last 20 years has not increased. It's around 115, and the person who dies at 116 in June has been replaced by someone else who's 116. And when they die, they'll be replaced by someone who's 113. So we're not increasing the maximum life expectancy. And what that means, I'll just go back, is that we've run up against the ceiling of decreasing mortality by stopping people dying when they're young, because there's not much you can do to get lower than 1%. And we're running on this axis here into the fact that while the maximum life expectancy might be 115, for most of it, it's less than that. So somewhere just beyond that dark blue line there is the maximum life expectancy for the rest of us. And so that's the challenge we're dealing with, and we have historically tended to treat people as if we can keep pushing that curve out indefinitely to the right. Right, so I've been thinking there have been sort of 3 phases of mortality. Before 200 years ago, you got sick and you got better, or you died. For the last couple of 100 years, we've been eliminating early death predominantly by public health measures and more latterly by health technology. And now death is predominantly due to degeneration and old age, and us approaching our individual maximum life expectancy. And from now on, until it all falls apart, that we will persist with those measures that prolong life with quality, but integrate appropriate care for those who have come to the end of their life. And I think that the thing that will happen is death will become explicitly re-recognised as a normal part of life. We've sort of forgotten that, and that's really what our project is about. Some of you may know Dennis Campbell, who was a surgeon in Townsville for many years. He retired, I think, about 15 or 20 years ago to the Sunshine Coast, and he died about a year and a half ago. And for me, he was the role model for dealing with people at the end of their life, because he taught me about, or I observed him, he didn't teach me actively, but just seeing the way he dealt with people at the end of life, he was a fantastic model for talking to people about what was important to them, finding out their issues, being able to communicate, and to talk to them candidly and openly about what was happening in a way that they could understand what was going on and embrace the recommendations and choices that he was making for them. And he was greatly involved in developing palliative care in Townsville as one of the leading lights who sort of opened all the doors when we were trying to get things going. Things I learned from him were about knowing our patients and establishing relationships with them so we can work out what's important for them, developing the skills in talking about death and dying, and opening. Sometimes we have to open the door for the patients because we need to know now about choices, or they may be reluctant, and sometimes we have to be there if the patient starts to open the door to help them open it and step through when they're willing to talk about themselves, because patients can initiate these things as well, and we need to recognise those signs. We need to know our community, and Dennis was certainly a very active member of his community and understood people outside of healthcare. And I think probably the most important thing we can do is that we help our patients to feel safe while they're dealing with really difficult things. So it's really important to be able to talk about these things, to help patients to better understand their hopes, goals and preferences, because sometimes people don't know what it is, or they've never had the opportunity or never been asked to think about what's important for them, to help them to make better choices, to help patients and their families to feel safe, I think it also helps us to gain greater satisfaction from our work if we do these things well, and that makes our lives easier and less stressful. I think it's also important to remember that generally at some level when we ask our patients if they understand what's going on, they will say things like, I thought that was going on, or they will recognise the things that are important, that have been happening to them, and know when things are deteriorating, and often they have a better sense of their life expectancy and what's happening than we do. I remember a patient who was the father of a friend of ours, and we thought he wasn't really being prepared. We'd gone and planned his funeral, and we all had to stand around the grave when he died singing "Que Sera, Sera," because he'd prepared his funeral service. They may actually be relieved that someone's talking to them, and I've had that happen a number of times. At last someone's talking to me. I've been being treated with this chemotherapy for 4 years and no one's ever talked about death. I had another patient who, when he came back from his scan which showed cancer, he said, now at least I know what I've got to deal with. And so the uncertainty had been removed about what was going to happen. And as we know, imagination generates more fear than reality. Knowledge is power, and patients can regain some sense of control over their lives. It's not our information, it's their information. We don't need to hold secrets about them. Also, if we don't know what people want, we can't do the right thing by them. And I guess really sometimes these things happen. It's better if we can plan things in advance and the patients have made their plans, but things happen to patients that are unexpected, but it's really important then to find out what's going on. In fact, it's almost more important. I was in a teleconference the other day and there was a specialist from a large hospital somewhere in Australia who said, the junior doctors don't have time to do advanced care planning, they're too busy treating the patient. So I said, in fact, actually, I don't see how you can treat the patient unless you've actually had some conversation with them about what's important to them. And that sort of stopped that conversation. I think that if we're making quality of life, end-of-life care available to all, which is the title, we need to encourage our patients to plan early, and we should all contemplate our own mortality and our goals and wishes. Who has an enduring power of attorney? Okay. Who has told their family what their wishes would be if they had some sudden head injury? Okay. Anyone documented an advanced health directive? Okay. A few people. So we all have done some of these things, or at least most of us have probably thought we should do them and haven't done them. And I went to the Advanced Care Planning Conference this week in Melbourne, and I realised I haven't actually written down what my wishes are and values are, and probably now that I am a young elder person, I actually need to document it rather than just have my family know. They all know, mind you. So we need to find out what our patients hope for and help them to set achievable goals, but our side of the equation is only to offer things that we think are going to be beneficial. I'll talk about that in a moment. We need to have those conversations with our patients about what we're offering and what their choices are and what the outcomes are going to be, so they can make good choices from the things we're offering. And we need to also, if we're not able to achieve the things they want, they need to know what kinds of things we can do for them. That includes, of course, the palliative care options and what kinds of supports are going to be available for them. Advanced care planning I think should be a lifelong process. It's something we can start when we're young, and one of my sons joined the Army Reserve, and they made him do an enduring power of attorney and talk to his family about what his wishes are. And I know all the soldiers who go overseas, they have to do that as part of their planning process, because they recognise that bad things can happen to people. And so part of that is contemplating our mortality and our choices. There's a nice ACDC, which I think is a nice acronym we can remember, which is appointing an enduring power of attorney, communicating our wishes, documenting our wishes, because we need to tell people, but if we write them down, that adds extra weight. We need to circulate our documents, so they need to be kept in a place where people can find them. Leaving in the top drawer under your underwear doesn't help much if you're taken to the emergency department from a car crash. So there are mechanisms available now in Queensland Health particularly, or in Queensland generally, where you can upload your statement of choices, which I'll mention in a second. Obviously what you do depends on your age and your health, so now I'm getting older, I need to do it. If you're young and well, you may just do an enduring power of attorney and talk to your family. So the questions we might pose to a patient: what preparations have you made? Do you have a will? Have you appointed an enduring power of attorney, and who is your decision maker? Have you engaged in advanced care planning? And the Statement of Choices document, which I'll show in a second, is available throughout Queensland. Do you have an advanced health directive, which some people do as a very specific request? And I guess as surgeons, the group you've seen most often are those people who are Jehovah's Witnesses, who would be the group you'd deal with most commonly, I would think. And as clinicians, have we written an acute resuscitation plan? Because some patients with known illnesses have already had these conversations somewhere else. So if they rock up in the hospital, they may have that kind of plan. They may bring it with them, because palliative care services certainly often send their patients home with a completed acute resuscitation plan that will make decision making really easy, because the decisions have already been made. This is the Statement of Choices form, which has been developed in Metro South and is, as I said, widely available. It will be reviewed, as all forms will be, but it offers the patient the opportunity to make a common law statement about what their wishes are in terms of CPR and other medical treatments. I think the more important part is where they record personal values, because they're much more useful as a guide to complex decision making. I found the old AHD form, the current AHD form, quite onerous in the sense that it asks you to make binary choices about things which are not really binary decisions to make. Like, do I want antibiotics? Well, I might if I have a urinary infection or an abscess, but I might not if I've got terminal pneumonia. Ticking a box doesn't help that. But completing the form at least gets something in there so people can be guided in their decision making. Some people say, oh, this is about saving money or we're going to get less good outcomes. But this is a trial that was done on patients with non-small cell lung cancer in Boston, and they took a large group of people and they randomised them into two groups. One had standard care and was referred to the medical oncologist and had the standard treatment, and that's the blue line. And the other line was the red line. They were referred to the same medical oncologist group, and they had a palliative care consult as well. And the palliative care consult was actually not just a palliative care consult talking about palliative care. They actually became involved in the decision-making process and went along to all the key decision-making point events in the person's illness. And what they found was that the patients who had the intervention had better symptom control, were less likely to be depressed, better quality of life, had fewer interventions, and lived longer. So sometimes not doing stuff actually is better for you than doing stuff. These are a couple of quotes from Good Medical Practice, which is the code of conduct which governs our behaviour and which we all should have read, and it has a section about care at the end of life. And we need to understand the limits of medicine in prolonging life and recognising when efforts to prolong life may not benefit the patient. We do not have a duty to try to prolong life at all cost, and we have a duty to know when not to initiate and when to cease attempts at prolonging life, while ensuring relieving distress. We have to accept that patients have the right to refuse medical treatment or request the withdrawal of treatment already started. We respect different cultural practices. We need to facilitate advanced care planning and provide or arrange appropriate palliative care. So this is core care at the end of life business, which we all need to participate in, and it's part of what's expected of us as medical practitioners. So when I wrote a letter back to the editors of the Internal Medicine Journal, and this was my comment, which was the value of approaching death as normal is that it allows us to focus greater attention on the goal of quality of life rather than life prolongation, and to embrace palliative care earlier when it reflects the reality of a patient's medical condition. This can lift a great burden of unfulfillable expectations from the shoulders of patients, families, and perhaps most significantly in the context of this article, from health workers. And I think that actually, if we are liberated from the idea we have to cure everyone and stop them from dying, it actually makes our work a lot easier. And people say, oh, palliative care must be really difficult. And I say, well, actually, no. It's not about the destination, it's about the journey. I can have 100% mortality and 100% success. And I measure my success not by the fact they're dying, but by the fact that I can keep them comfortable and give them the best possible quality and help them to accept the normality of their death. Thank you.